I'm Rachel Outerson, a clinical assistant professor of anesthesia at Stanford. This lecture will be on the pharmacology of local anesthetics. In this lecture, we will discuss the structure of local anesthetic molecules, the mechanism of action of a local anesthetic, clinically relevant molecular characteristics that confer different properties to individual drugs, metabolism, and finally we'll review the medications which may be used as adjuncts to alter clinical effects of local anesthetics. Local anesthetics are pharmacologic agents that are used to prevent conduction of nerve impulses and therefore abolish sensation. While there are several different agents in this category, they all share the same basic structure, with an aromatic ring at one end, a hydrocarbon chain with either an ester or an amide linkage in the middle, and a tertiary amine at the other end. While the aromatic ring is lipophilic, the tertiary amine is hydrophilic. In solution, they exist in equilibrium between the neutral base and charged acid forms. The neutral base forms are more soluble in lipid environments, whereas the charged acid forms are more soluble in water. The two basic subfamilies of local anesthetic drugs are aminoesters and aminoamides, named according to the bond in their intermediate chain. The archetypal aminoester is cocaine, the only naturally occurring local anesthetic, and the first one ever used clinically. The aminoamide family includes most of the local anesthetic agents we commonly use for regional anesthesia at Stanford, including lidocaine, bupivacaine, ropivacaine, and mepivacaine. Two interesting amide local anesthetics to note here are ropivacaine and levobupivacaine. Both of those are single enantiomer local anesthetics. They're S enantiomers, resulting in lower cardiac toxicity compared to the R enantiomer or racemic mixtures. All other local anesthetics exist either as racemic mixtures or have no asymmetric carbons. The site of action of a local anesthetic is at the transmembrane voltage-gated sodium channel in a nerve axon cell. These channels, when activated by depolarization of the membrane, open, allowing an influx of positively charged sodium ions that allow an action potential to propagate along the nerve. After activation, they immediately enter an inactivated state and then recover to a resting state as the membrane potential is restored to normal by membrane sodium-potassium pumps. When the local anesthetic agent binds to an intracellular binding site on this sodium channel, the channel is stabilized in its inactive form, unable to open and allow passage of sodium ions. If enough channels are rendered inactive, conduction of the nerve ceases entirely. In order to reach the voltage-gated sodium channel, the local anesthetic molecule first must traverse the lipid membrane of the cell. This is only possible when the local anesthetic is in its uncharged base state. Once intracellular, the local anesthetic can bind to the voltage-gated sodium channel, and this is only possible when the local anesthetic is in its positively charged state. The aromatic ring end of the molecule binds to the intracellular binding site of the channel, and the charged hydrophilic tertiary amine end protrudes into the sodium channel's lumen. The local anesthetic molecule is more likely to bind a voltage-gated sodium channel when that channel is in its activated or inactivated states. The resting state has a much lower affinity, so repeated depolarizations of the cell, causing repeated activation and inactivation of the sodium channel, will increase the likelihood that a local anesthetic will encounter a sodium channel in a form that it can bind. This is what is known as use-dependent or frequency-dependent block. The clinical significance is that a nerve that is actively conveying signals, for example when the patient is experiencing pain, will achieve blockade faster than one that is resting. Now, notably, the mechanism of toxicity of local anesthetic agents involves quite a few different mechanisms in addition to sodium channel blockade, and that is the subject of a separate lecture on this site. Let's discuss some of the clinical properties of different local anesthetics and how they relate to characteristics of the individual agents. The first property of interest is the speed of onset. The rate-limiting step and speed of onset of a local anesthetic is traversing the cell membrane in order to gain access to the intracellular portion of the sodium channel. This step, as I mentioned earlier, is determined by the proportion of local anesthetic molecules that exist in an uncharged form. This is a characteristic we call the pKa. The pKa is the pH at which the ionized and unionized form of local anesthetic are present in equal amounts, as demonstrated by the Henderson-Hasselbalch equation. For bases, such as local anesthetics, the higher the pKa, the greater the fraction of molecules will be in their charged form in solution. Therefore, the higher the pKa, the fewer uncharged molecules are available to cross the cell membrane, and the slower the onset. This explains why lidocaine, with a pKa of 7.8, has a faster onset time than bupivacaine, which has a pKa of 8.1. Now, from what we've been discussing, it would seem that chlorprocaine, which you can see from the graph has a pKa of 9.1, would have a slower onset time than bupivacaine or lidocaine, but this is not observed clinically. And the reason for this is the dose. Chlorprocaine is given typically as a 3% solution at a significantly higher dose than either bupivacaine or lidocaine. The higher number of molecules of chlorprocaine injected make up for the fact that a smaller fraction of those molecules exist in the uncharged form required to traverse the lipid bilayer and enter the cell. We are able to use chlorprocaine in such doses because of its comparatively low risk of toxicity. And molecular weight also has a role to play in speed of onset because of the aqueous diffusion rate, which will be faster with smaller molecules. Next, let's talk about potency and duration of action of local anesthetics. As a rule, lipid solubility, greater molecular weight, and potency are all closely related. Larger, more lipophilic local anesthetics are more able to traverse cell membranes and more readily bind to voltage-gated sodium channels. Greater protein binding by a local anesthetic to alpha-1 glycoprotein is associated with longer duration of action, and this binding also results in a lower bioavailability. Now, these two properties of potency and duration of action tend to trend together. Larger, more lipophilic, more potent agents also tend to be long-lasting agents with greater protein binding. Such agents also tend to have a slower onset of action and to be more toxic. A great example of this particular combination of characteristics is bupivacaine, pictured here to the right. Vasoactivity also plays a role in potency and duration of action. Vasoconstriction can lead to increased potency and increased duration of action. Some local anesthetics, for example ropivacaine, may cause vasoconstriction at low subclinical doses, whereas moderate or high doses result in vasodilation, or even decreased SVR, which contributes to toxicity. Cocaine is the only local anesthetic that causes vasoconstriction at all doses. Absorption of local anesthetics depends primarily on the perfusion of the site of injection. Intercostal has the highest, down to subcutaneous having the lowest. The distribution of a local anesthetic in the body tends to be proportional to the tissue-blood partition coefficient of the individual local anesthetic agent. As a rule, ester local anesthetics are less protein-bound, and amide local anesthetics are more protein-bound. Metabolism of local anesthetics breaks down relatively neatly by family. The amino esters are metabolized primarily by plasmacetylcholinesterases, with a smaller contribution of hepatic metabolism. And this breakdown occurs fairly rapidly, resulting in plasma half-lives that range from 1 minute to chlorprocaine up to 8 minutes for tetracaine. The metabolite para-aminobenzoic acid, or PABA, is formed in the breakdown of ester local anesthetics and has been associated with allergic reactions in a small percentage of patients. Patients with atypical plasmacetylcholinesterase or with decreased acetylcholinesterase activity due to liver disease will have impaired metabolism and may be at greater risk for toxicity. Interestingly, the CSF does not contain any acetylcholinesterase, so amino ester agents administered intrathecally will persist until they are taken up and metabolized by esterases in the bloodstream, which explains why you can use chlorprocaine for a spinal anesthetic and it won't wear off in 1 minute. The only ester that is an exception to the acetylcholinesterase metabolism rule is cocaine, which undergoes significant hepatic metabolism and then renal excretion. Amide local anesthetics undergo metabolism by hepatic cytochrome P450 enzymes. So amide metabolism is in general quite a bit slower than ester metabolism. And of course, patients with decreased hepatic function or decreased hepatic blood flow, as can happen in heart failure, will be at greater risk of toxicity from these agents. The amide local anesthetics are not metabolized to para-aminobenzoic acid, and so allergic reactions to the agents themselves are very uncommon. However, solutions of these drugs may contain preservatives, such as parabens or sodium bisulfite, that are more likely to cause allergic reactions. Placental transfer of local anesthetics is an important aspect to consider when administering local anesthetic, particularly by epidural infusion to a parturient. The rate and degree of diffusion of local anesthetic across the placenta depends on protein binding and pKa of the agent, as well as maternal and fetal pH. Local anesthetics that are more highly protein bound, such as bupivacaine, will be less likely to diffuse across the placenta than those that are less protein bound, such as lidocaine. Fetal blood is slightly more acidic than maternal and can become significantly more acidotic during fetal distress, as may occur during prolonged labor, resulting in the potential for accumulation of local anesthetic in the fetus due to a phenomenon called ion trapping, where a greater proportion of local anesthetic molecules assume their charged hydrophilic form due to the lower pH in the fetal bloodstream and are thus less able to diffuse back to the maternal circulation. This also happens with other weekly basic drugs, such as opioids. This does not tend to be a concern with ester local anesthetics, which rapidly hydrolyze in the maternal circulation. Many agents have been studied as adjuncts to speed onset, prolong effect, and reduce total required dose of local anesthetic. Probably the most commonly used is epinephrine, which, thanks to its vasoconstricting effects, can delay systemic uptake of local anesthetic and therefore prolong its effect and reduce toxicity. It can exert this effect with a concentration as low as 1 to 800,000. Bicarbonate can be used to alter the pH of a solution, allowing a greater proportion of local anesthetic molecules to be uncharged in solution, and therefore allowing for a faster onset. This has been demonstrated to work when mixed with mepivacaine, but to slow onset with other local anesthetics. Opioids, such as buprenorphine and tramadol, have been shown to improve duration of block, likely due to action on peripheral opioid receptors. In the case of tramadol, it is suspected that its action as an SNRI may also contribute. Dexamethasone is a potent corticosteroid that we commonly use to prevent postoperative nausea and vomiting, and that is known to have analgesic effects on its own for up to 24 hours with a single IV dose. However, it also improves the quality and duration of a peripheral nerve block when combined with local anesthetic. And perineural administration, when mixed with local anesthetic, is associated with a longer, better block than IV administration concomitant with a local anesthetic peripheral nerve block, in a way that is statistically significant, but debatably less clinically significant. Alpha-2 agonists such as clonidine and dexmedetomidine seem to have innate local anesthetic properties of their own and can prolong the duration of other local anesthetics when given together. This effect is more significant when added to short-acting local anesthetics such as mepivacaine. They do have side effects you might expect of hypotension, bradycardia, sedation, and syncope. In any case, the choice of a local anesthetic adjuvant must be given balancing the expected benefits and potential risks of the particular agent. In summary, local anesthetic agents are weak bases that have their mechanism of clinical action at the intracellular aspect of voltage-gated sodium channels. The rate-limiting step to onset is traversing the cell membrane, which is a charge-dependent phenomenon, making the pKa and the pH very important. Larger, more lipophilic local anesthetics tend to be more potent, slower in onset, longer lasting, and more toxic. Metabolism of local anesthetic agents is different according to family, with esters primarily being rapidly hydrolyzed by esterases, and amides undergoing hepatic breakdown. And adjuvants may be used to enhance the properties of local anesthetics, speeding onset, decreasing systemic uptake, and prolonging block. Thank you.